also refractory errors of the eyeball now. Okay, everybody? So we have done two parts. If you say, everybody, number one, we have recorded the vision. Number we have seen. Number two, we have seen that if the vision is normal, the optical system is normal, and how the optical system values have come into effect. If the vision is abnormal, there is some refractory errors. So that is the part 3 that we are starting now. Refractory errors, broadly saying, can be divided into two groups, everybody. They can be spherical refractory errors or cylindrical refractory errors. There are two spherical refractory errors which we should know, which we should have heard of. Myopia and hypermetropia. Whereas the cylindrical refractory error is known as astigmatism. Am I clear, everybody? So these are the three main refractory errors that we want to study. Yes? We will start discussing myopia and hypermetropia, the spherical refractory errors, and then we will move on to astigmatism. Now, myopia and hypermetropia. Let's discuss them in layman language first before going into the details. Let's say I take an example of a student. Let's say there is a student called Rahul watching the lecture right now. And let's say Rahul is wearing a spectacle of -2D. -2 power, -2 diopter. Now my question to Rahul and all the other students is, why is Rahul wearing a spectacle of power -2? In simple language. I don't want big answers. Why is he wearing -2? He is wearing -2 because his power of eye during development did not stop at 58.6 diopters. During development, the power of the eye reached to 60.6 diopters. Converging power increased. When the converging power increased, he had some problem in vision. So he said, I want to make my power of the eye normal. So he started wearing a spectacle of power -2. 60.6 -2 will be 58.6. That means he is wearing a spectacle of minus power because the power of his eye is more. Can I say? Because the power of his eye is more, the spectacles he is wearing are minus. Because the power of his eye is more, the parallel rays of light that are coming from infinity are converging with greater power. When they are converging with greater power, they will converge before the retina. Yes or no? More power means lesser distance required. When the light rays converge in front of the retina, we call it myopia. I hope you understand. So myopia is basically due to more power. More power leads to image forming in front of the retina, and that is why you have to wear a spectacle of minus power. The power is more, so you want to decrease it and you wear a minus. So that's the simplest way to remember myopia, everybody. M for myopia, M for more power, M for minus spectacles. This is what I will be using to explain you everything in myopia. When you will do the opposite of it, you will get hypermetropia. I hope I am clear on this. Right, guys? So let's start with discussion of myopia and hypermetropia based on what I have just explained in layman language. I will be discussing in a comparative table, everybody, side by side, myopia versus hypermetropia. So, myopia versus hypermetropia. First of all, I'll just draw a simple line diagram for all of you. Cornea, limbus, sclera, lens. So, if I say the definition, parallel rays of light coming from infinity converge in front of the retina. It becomes a case of myopia. That is why by the time light reaches the retina, there is a small circle of blur. There is not a point image which is formed. Okay. Similarly, if I draw the same line diagram, simple for hypermetropia, parallel rays of light coming from infinity converge with lesser power. So they finally go and are able to converge behind the retina. again you will see that while they have crossed the retina, because they have not been able to converge, there is a small circle of blur on the retina. That is why the patient has some blurring of vision in both the refractive errors. Okay. Now, if I just want to write it in simple words for you, everybody, in myopia, the power of eye is more, and that is why the image is formed in front of retina. Very simple thing, guys. Hypermetropia, power of eye is less, and that is why image is formed behind retina. Okay, nothing new, guys, just what has been explained to you through the example of Rahul. That's all that I have written here in simple language now. Okay, now after we know this much, the question that comes into my mind is, why is the power increasing in myopia, or why is the power decreasing in hypermetropia? The power has to increase or decrease, but what are the causes? So let's see the mechanisms or the causes. So again, we will be discussing them in a comparative table between myopia and hypermetropia. I will explain things in myopia. I'll just reverse it and they will become the causes for hypermetropia. So mechanisms of myopia, mechanisms of hypermetropia, short form HMT. Myopia, mechanism number 1, everybody. Axial myopia. Axial myopia. As soon as I say axial myopia, you understand that I must be talking about some problem with the axial length of eye. As already explained by the listings, reduced eye, axial length of eye determines the power of the eye. Yes? Now for causation of myopia, everybody, axial length should increase or should decrease. If you apply your common sense, you will be able to understand this. For myopia to occur, image has to form in front of the retina. So if I stretch the eyeball, if I make the eyeball longer, yes, the image will start to form in front of the retina. So that means for causation of myopia, the axial length is increased. And for hypermetropia, the axial length is decreased. A shorter eyeball, the light will converge behind the eye. Am I clear? Now, the formula is 1 millimeter increase in axial length. I hope you're understanding the cryptic language. 1 mm increase in AL, axial length, is equal to 3 diopter myopia. 1 mm increase in axial length is equal to 3 diopter of myopia. Done? Now, secondly, curvatural myopia. Curvatural myopia. Again, I hope you understand I must be talking about the curvature, mainly of the cornea here. See, the curvature of the lens, unless there is a pathology like lenticonus, it doesn't change actually. Okay, it is a normal process in accommodation to change the curvature. The lens becomes more round. So we're not talking mainly about the lens, we are talking about the corneal curvature. Now, if you know your optics, if you know your physics, as the curvature increases, curvature means the roundness, yes? As the curvature increases, the power increases. So for myopia, I have to increase the power. So I have to increase the curvature. Similar fundamental we had used in accommodation, everybody. In accommodation, the power of the lens increases because the anterior curvature increases. Yes, curvature increase is equal to power increase. But curvature is the opposite of radius of curvature. Radius of curvature will be decreased. I don't know if you understand this. I hope you do. If you don't, I will just use this simple example of the lens only. This is the anterior surface. This is the posterior surface. Okay. We say the anterior surface is flat. I am using the example of lens to explain you this. We say the anterior surface of the lens is flat. Flat means less curvature. but the radius of curvature is 10 mm. This is what we have explained and written in the lecture on lens. The posterior surface is curved. As you can see also, curved means more curvature. More curvature means radius of curvature is actually lesser at 6 mm. Am I clear to everybody? So I can say curvature is inversely proportional to radius of curvature. Simple physics, everybody, simple maths. I hope you learned this. This can complicate a lot of issues, so I hope you don't get into the problem here. Okay? Done? So going back, everybody, we have said that the curvature will increase. If the curvature increases, the radius of curvature will actually decrease. We can do the opposite for hypermetropia. In hypermetropia, we say the curvature will be decreased, but the radius will be increased. Am I clear? Now, third mechanism, everybody, I can call it index myopia. Index myopia is based on refractive index of lens. Refractive index of lens. This also has been told to us by listing. When the difference between the refractive index from one medium to another will be increased, the power will be increased. So normally air has a refractive index of 1, lens has a refractive index of 1.40. But if the refractive index of the lens becomes greater than 1.40, the difference will increase, the converging power will increase. So that means when the refractive index of the lens is increased, the power of the eye is increased, thus causes myopia. The opposite will be true for hypermetropia. Then lastly, everybody, positional myopia. Positional myopia depends upon the position of lens. If the position of the lens is anterior, myopia will occur. If the position of the lens becomes posterior, hypermetropia will occur. Okay? Why is that so? Because of the formula, power is equal to 1 divided by focal length. Okay? What do you mean by this? If this is my lens and this is the object, then this is f1, focal length. Yes or no? This distance is f1, as again told to us by listings reduced eye. Okay? If the lens moves forward, if the lens moves anterior, that means now the f1, which is new, is decreasing. If the f1 will decrease, the power will increase. So lens becoming anterior, the power will increase. Am I crystal clear about this, everybody? So these are the mechanisms of myopia and of hypermetropia. Please remember the simple formula, B is equal to 1 divided by F. Am I clear? Now, we know this. If I want to say in one line, I can actually say, for myopia, everything is more. The power of the eye is more. The axial length is more. The curvature is more. The index is more. And even the position is moving in front. The focal length is decreasing, but the way to remember it is that the lens is moving in front. आगे बढ़ रहा है, हिंदी में हो गए. आगे बढ़ रहा है मतलब increase हो रहा है. Am I clear to everybody? Are we clear? So for myopia, just remember the word more and you should be able to remember 90% of it. Myopia means more, M for M. Now, this is the easy part. The difficult part comes when we ask you to correlate. We've already seen the lecture on lens, everybody. If I ask you, from lens, can you find out one cause, one pathology which will lead to positional myopia? One pathology which will lead to positional myopia. What you need to think? Lens moving anterior. Anterior means forward march. Forward march. March, march, march. Wheel Marchesani syndrome. Student said difficult question was asked. There is nothing called difficult. It's all about your correlation, guys. You know Wheel Marchesani syndrome, you know positional myopia, you just need to correlate both of them. So Wheel Marchesani syndrome causes positional myopia. Similarly, in the chapter on lens, we have already discussed nuclear cataract. Nuclear cataract causes sclerosis, increases the refractive index. That is why the power is increased, and that is why it leads to index myopia. Similarly, we have discussed the word ophthalmos in the chapter congenital glaucoma. Yes or no? Congenital glaucoma leads to enlarged eyeball. Enlarged eyeball means axial length is increased. Ophthalmos, axial length is increased, will lead to axial myopia. Done? And if I say here keratoconus, this has been covered in the chapter on cornea, guys. If you will see, keratoconus, cone-shaped cornea, the curvature will increase in a cone, and that is why it will lead to curvatural myopia. Right? This is what I want you to do. I want you to be able to correlate. I have written certain correlations here for all of you. Done, everybody? So these are the mechanisms of myopia and hypermetropia. Now let's discuss the symptoms of both myopia and hypermetropia. Probably the easiest thing, guys. Yes, as far as myopia and hypermetropia is concerned. A lot of you who are wearing spectacles, if you remove your spectacles, you are myopic, guys. If you remove your spectacles, what will be your symptom? You won't be able to see clearly at far. Yes. So myopia presents with loss of far vision. The patient cannot look at a far object. But though the patient cannot look at a far object, near vision is clearer. That is why it is also known as short-sightedness or near-sightedness. I hope there is no confusion in this. I can't look at far, but I can look at near. The opposite will be true for hypermetropia. There will be loss of near vision, or which can be known as long-sightedness or far-sightedness. Again, I hope there is no confusion. I can't look at near, but my far vision is absolutely normal. Okay, basic things. Now, apart from the loss of far vision in myopia, the patient also complains of floaters. Floaters means the patient will say that I see some black or some transparent flying objects throughout the day in my vision. Floaters. They occur due to vitreous liquefaction. With high myopia specifically, the vitreous, which was a gel, starts to liquefy a little, and that leads to floating. Basically, there are water spaces, yes, which are floating. So you see some shadow being cast on the retina. So you see some black small dots or some lines floating. Okay. Similarly, another important complaint by hypermetropic patients is asthenopia. We must have come across this word a lot of times when we read optics, everybody. But what do we mean by asthenopia? In simple English, if I say, tired eyes. Tired eyes. Now the question comes, why does hypermetropia cause asthenopia or tiredness of the eyes? The answer is very simple. Hypermetropia is loss of near vision. So to adapt, my near reflex becomes overactive. Near reflex, if you remember, consists of three parts: accommodation, convergence, meiosis. Accommodating by ciliary muscle, converging by medial rectus, meiosis by sphincter pupillae. So I have to use these three muscles more, everybody. When you use your muscles more, they get tired. When they get tired, you start feeling heaviness. As simple as that, everybody. Okay? So usually we see that children with hypermetropia actually do not complain of loss of near vision, because their near vision is being taken care by adaptation, by overworking of near reflex. Instead, they go home and they complain. After school, they will go home and they will tell their mothers and parents, everybody, that we have heavy eyes. But the mother loves, Indian mothers specifically love their children. So they will feel, oh, mera bachcha nikamma ho gaya. My child doesn't want to study anymore. That's why he is fiending, malingering. The mother will shout, hate everything. But the child is actually telling the truth. The child has hypermetropia. The child is feeling asthenopia. So never ignore an asthenopic child, guys. It is usually a case of uncorrected hypermetropia. Am I clear, everybody? Basic symptoms of myopia and hypermetropia. After symptoms, everybody, what do we want to know? We want to know the signs. Again, signs of myopia versus signs of hypermetropia. In myopia, if I start with the easiest thing, the eyeball, is large. Because of increase in axial length, remember everything can be correlated with another thing. Because axial length is larger, the eyeball is large, I will say. This large eyeball leads to decrease in scleral rigidity. This leads to increase in scleral rigidity. Okay. This has to come into effect when you are doing a surgery in a high myope. Because the scleral rigidity is lesser, you need to be more cautious of doing any surgery. Whereas in hypermetropia, because the axial length is lesser or decreased, the eyeball is small. Similarly, if I ask you a very basic question, depth of anterior chamber in myopia, everybody. Because the whole eyeball is becoming large, the anterior chamber will become deeper. Whereas in hypermetropia, it becomes shallower. Because the anterior chamber is shallower in hypermetropia, that is why hypermetropia is a risk factor for angle closure glaucoma. This has been explained to you in glaucoma chapter also. If you can correlate everybody, that is why hypermetropia, because the eyeball is small, because the anterior chamber is shallow, that is why it can lead to angle closure glaucoma. Then, thirdly, everybody, very important point, that myopia leads to exophoria. Myopia leads to exophoria. The question is why? Exo means which deviation, everybody? Outward deviation. But why, everybody? Why? Because, see, in myopia, what is occurring? My far vision is getting lost. If I talk in optical terms, my far point is usually at infinity, yes or no? That is why we say parallel rays of light coming from infinity. Now my far point comes closer to me. That is why I lose my far vision. So my far point comes closer. Because my far point has come closer, that is why actually this is aiding in near vision. So the patient does not need to accommodate for near. Okay? The finite far point becoming closer is aiding near vision. So you don't need to accommodate now for near vision. When you don't accommodate for near vision, you don't converge for near vision. No accommodation is equal to no convergence. This is a triad of reflex. No accommodation, no convergence. Thus, the patient develops convergence insufficiency. Convergence insufficiency presents as exophoria. The eye forgets how to converge. So instead of converging, it gets into the mode of slightly diverging. Diverging means going out, and thus I say develops exophoria. I hope you are clear about this. I hope there is no confusion about this. Am I clear to everybody? Done? Now, if I talk about hypermetropia, hypermetropia leads to esotropia. Has been explained beautifully already in the lecture on squint. I'll just reiterate it. Due to uncorrected hypermetropia, more near reflex means more accommodation, more convergence. More convergence means eyeballs come in means esotropia. Am I clear to everybody? So hypermetropia will lead to esotropia, whereas myopia will lead to exophoria. Again, I will ask you to remember this mnemonic, commonly asked. So hyper. So means eso, hyper means hypermetropia. Hypermetropia is associated with esotropia. Right, guys? I hope you already remember this. If not, this is a recap for you. Now, let's move on. Let's discuss more signs. Point number 4, everybody. Point number 4, I am writing fundus signs. Now, When I say fundus signs, what am I talking about? This word fundus, everybody, what does this word fundus mean? If you have not seen the lecture on retina still, then what does the word fundus mean, everybody? Fundus. What is fundus? I'm asking all of you, think about it. If you say fundus is retina, fundus is a part of the retina, fundus is optic disc, fundus is anything that you say related to retina, you are absolutely wrong. What is fundus? Let me explain it to you. What is fundus? Everybody. This is my eye, again cut section, simple everybody. Okay. Let's say I give you a torchlight, everybody. Through the torchlight, I ask you to examine my cornea. Can you examine my cornea? Yes. Cornea can be visible through a torchlight, naked eye examination. Can you see the pupil constricting and dilating on torchlight? Yes. We can do the light reflex on torch. That means we can see the pupil. That means we can basically see the iris. If you know a little bit about lens, cataract, can we see the color of the cataract? Pearly white, dirty white, yellow? Yes. That means through a torchlight, I can see the cornea, I can see the iris, I can see the lens. That means through a torchlight, I can see the anterior segment of eyeball. Okay? But if I say, can you see the vitreous through torch? No. Can you see anything in the posterior segment by a torchlight? You will say no. So that means to see the posterior segment, you will need to use an instrument. That instrument will be called as an ophthalmoscope. Okay? Ophthalmoscope. Now when you are using an ophthalmoscope, what are you visualizing? You are visualizing the vitreous. But vitreous is what, everybody? Transparent. Because vitreous is transparent, you can see the vitreous and then you can see the part behind the vitreous. What is behind the vitreous, everybody? Retina. Now my question to all of you, if you know the answer, what is the color of the retina? Red, yellow, orange, brown, black, white, or transparent? If you're saying red, yellow, orange, you are absolutely wrong. You don't know what is fundus. That's why you are wrong. Retina is also transparent. Because retina is also transparent, you can see the layer behind the retina, everybody. What will be the layer behind the retina? Think about it, everybody. See, there are 3 layers, no? If I just draw it like this, a very crude diagram. Retina is the innermost layer, sclera is the outermost layer. So what is this layer, everybody? Uvea. Uvea is a vascular layer. Uvea consists of blood, choroid. Blood means which color, everybody? Red color. So because the vitreous is transparent, because the retina is transparent, that is why you will also be able to see the choroid. What is fundus, if I ask you the question? When I do ophthalmoscopy, I am able to see a view. A view of 3 things. Number 1, vitreous. Number 2, retina. Number 3, choroid. Whether I want it or I don't want it, I will see these 3 things together because the first 2 things are transparent. And this view of all the structures together in the posterior segment is said to be the fundus. Am I clear to everybody? So what is fundus, if I ask you now? So fundus is a view of all structures visible in the posterior segment. Am I clear to everybody? What is visible? A and B, vitreous and retina, both of which are absolutely transparent structures. Because of that, you are able to see the choroid. Choroid is red in color. Choroid is red in color. Okay? Am I clear? So this is fundus. And that is why, if you have heard, we say fundal red reflex. That whenever we try to do retinal examination, we are actually not doing retinal examination. We are doing fundal examination, and fundal red reflex is there because of the choroid. Retina is transparent. Okay, everybody? So when I say fundus signs for myopia or fundus signs for hypermetropia, if you understand this, you understand I am talking about signs in the posterior segment, whether they be in the vitreous, retina, choroid, anywhere. Okay? So let's see, everybody. Fundus signs of myopia and hypermetropia. I'll first of all write 2 signs of hypermetropia. The first sign is pseudo-papillitis. Papillitis means an inflamed swollen disc, but actually it is not swollen, it just looks swollen. That is why pseudo-papillitis. There is no inflammation. Secondly, short silk fundus. Short silk fundus. When you examine the fundus gives a shining reflex, everybody. So it is said to be shining like a silk sari, short silk fundus. That's all. Done. Non-significant, not important, just remember the two names. Let's move on to the fundus signs of myopia. They are what is important to us. Fundus signs of myopia are seen only in cases of pathological or degenerative myopia. They are seen only in cases of pathological or degenerative myopia, only in a subset of cases. So what is pathological or degenerative myopia? If myopia is greater than 6 diopters, or if the axial length is greater than 26 millimeters. Okay? Then only you classify the patient as pathological or degenerative myopia, and then you say that the chances of all these fundus signs is much more. So if you are a normal myopic, -1, -2, you are not likely to have at all these fundus signs. Am I clear to everybody? Now, let's see what will be the signs, everybody. So what are the fundus signs of myopia, everybody? A. The first sign that we see is temporal myopic crescent. Temporal myopic crescent. This is an area or a zone of chorioretinal atrophy around the optic disc on temporal side. A zone of chorioretinal atrophy, everybody. If I draw the image for you, I hope you will be able to relate to your glaucoma lecture. This is my optic disc, optic cup. These are my blood vessels coming out, everybody. There are two zones of atrophy, beta zone, alpha zone. If you can correlate your glaucoma chapter, everybody. Okay? This is my beta zone. This is my alpha zone. Alpha zone is only in glaucoma. Beta zone I had written also seen in myopia. So beta zone is equal to temporal myopic crescent. Can you see a white shaped moon, everybody? Yes or no? And that is temporal myopic crescent. Now, why does this appear white in color? Everybody, very simple. There are 3 layers, everybody. This is my retina. This is my choroid. And this is my sclera. Okay, everybody? So, retina, choroid, sclera. I am saying there is retinochoroidal atrophy. So, around the optic disc, due to the elongation, everybody, axial length increases. Due to the elongation, this retina and choroid are stretching. Yes, and because they are stretching, they are getting atrophied. So, let's say I am saying that they are getting atrophied in this area. Okay? If they get atrophied in this area, when I visualize the fundus, everybody, what will I be looking at? I will be looking at sclera. Sclera is white in color. So around the optic disc, there is stretching of the retina and choroid leading to atrophy, and that is why I can see the sclera in the fundus. Appears white in color. That is why likened to a moon. Yes, everybody, temporal myopic crescent. I hope you will not have any problem in understanding this. If I show you the actual photograph of this, everybody, let's see this photograph. If you can make out the optic disc, everybody, this is the optic disc. Around the optic disc, everybody, if you see this large area, whitish appearing area around the optic disc, everybody. Yes? So this is your temporal myopic crescent. I hope there is no confusion in this. Done? Now, let's move back, everybody. Next sign. So this was sign A. Now sign B, everybody. The second important sign is called as tessellated or tigroid appearance of fundus. Why does this occur? This occurs due to diffuse attenuation of retinal pigment epithelium. Okay. So at some places the layer of the retina which contains the pigment, it attenuates, some places it doesn't. So what you see is basically at some places you will be able to see clumping of pigment, so you will be able to see black lines, then your normal reddish looking fundus, then again you will be able to see some clumping, then again some reddish normal looking fundus. Okay, so I like to remember it as braiding of hairs. When you look at the fundus, you will see in between small streaks of black lines. Okay, everybody? Now, third important sign is known as supertraction. Supertraction leads to tilted optic disc. Just remember this. The optic disc appears slightly tilted, everybody. Then the next important sign is known as lacquer cracks. Lacquer cracks. What are lacquer cracks, everybody? They are fine breaks in the Brooks membrane. Fine breaks in the Brooks membrane. What was Brooks membrane, everybody? Again, remember the basic anatomy of the eye. Brooks membrane was the innermost layer of choroid. Now everything is occurring because the eyeball is stretching. When the eyeball is becoming longer, it is stretching. The innermost layer of the choroid, Brooks membrane, is breaking. When it is breaking, you can see fine breaks. Why is it called lacquer cracks, everybody? If I use a Hindi word, tarred. Yes? When you polish a door, wood door, everybody, you polish it with lacquer polish. Or you apply nail polish, everybody, lacquer polish. If it is not applied properly, you will be able to see fine crisscross lines, yes? Either on the wooden polish or in your nail polish, everybody. And thus it is likened to lacquer polish. Fine crisscross breaks. If I show you the image, everybody, let's see this image, everybody. In this whole area, everybody, this, can you see fine crisscross breaks, everybody? Yes? And these are all lacquer cracks. In this case, you can see temporal myopic crescent also. Yes? And if you focus, this is temporal myopic crescent, everybody. I hope you don't get confused. This is lacquer cracks, everybody. And if you actually focus on the optic disc, does the optic disc appear round to you? No, no. It appears slightly oblique to you. So this is actually showing tilted optic disc. I hope you are able to make out. Yes? Compare the optic disc to the upper part. In the upper part, you are able to see a normal optic disc. But in the second image, the optic disc has become tilted due to supertraction. Done, everybody? No confusion, I hope. Okay, let's move back, everybody. Now, another sign, everybody, is called as Foster-Fuchs spots. Foster-Fuchs spots. What are Foster-Fuchs spots, everybody? They are areas of subretinal hemorrhage at the macula. Okay. So at the macula, everybody, below the retina, there will be hemorrhage. So they will be visible as dark red spots, which are called as Foster-Fuchs spots. I hope it is very clear. Yes. Then the next sign, important sign, is posterior staphyloma. Posterior staphyloma. Now, the staphyloma word we must have come across when we read our third year MBBS cornea chapter, if you remember. What is the meaning of the word staphyloma? That's my first question. Staphyloma means bulging. Now, bulging of what? Let's try to understand it, everybody. If I say this is my cornea, limbus, this is my sclera. Okay. Inside the eye, there is intraocular pressure, IOP. The pressure is pushing all the directions. Yes or no? It is trying to push everything. Now, what is occurring in myopia? Axial length is increasing. So posteriorly the eyeball is becoming longer. Yes or no? It's not that my cornea stretches and comes out. All the lengthening that occurs is posteriorly. So when posteriorly stretching is occurring, retina is stretching, choroid is stretching, retinochoroidal atrophy, lacquer cracks, everything. But sclera is also stretching. When I keep on stretching the sclera, sclera will get thinner at one point. Yes? So let's say in this area, my sclera has become thinner. Because my sclera has become thinner in this area, now the pressure inside the eye will push this part of the sclera out. So I will be able to see a bulge in the sclera. Are you getting my point? So axial length elongation leading to stretching and thinning. Thinning leading to bulging out due to the pressure inside the eye. And this bulge gets the name staphyloma. Why are we calling it posterior staphyloma? Sclera is which part of the eye? Anterior part or posterior part? Posterior part. So bulging of sclera. I hope you understand. Staphyloma means bulging, posterior means sclera. Yes, everybody, are we clear? Let me show you the actual photograph for this, everybody. See this. Concentrate between my arrows. Can you see, everybody? If you try to notice this carefully, it looks like there is a bulge down then coming up. Yes? Can you see that there was the fundus, then it goes down a little, then it comes up. So that part, this ridge, everybody in the center has bulged out. So this part is showing you posterior staphyloma. I hope I am clear in this, everybody. Yes? There are other types of staphyloma also, which we can see in this image, everybody. So, as you just saw, we have seen the posterior staphyloma, which occurs in the sclera. Okay? But there can be other types of staphyloma. Intercalary staphyloma. Intercalary staphyloma is bulging of the limbus lined by root of iris. Are we clear, everybody? So the limbus has bulged out, you will see, lined by root of iris. Now if I see ciliary staphyloma is bulging of sclera lined by ciliary body. Along with the bulge, the ciliary body is also getting bulged out. If I talk about equatorial is again bulging of sclera lined by choroid. Okay, it is called equatorial because it is occurring at almost the center part of the eye. But if bulging occurs in the cornea, everybody, corneal bulging, then I will call it anterior staphyloma. Am I clear to everybody here? Yes. So anterior staphyloma, cornea, posterior staphyloma, sclera, anterior, posterior, intercalary. Inter means beech mein limbus. Yes. Then there are two other varieties of scleral bulging, which are called as ciliary and equatorial, depending on the site actual. Okay. If it is scleral with ciliary body lining, if it is scleral with choroid lining. Am I clear to everybody? Yes. So these are our types of staphyloma. I hope you do not have any confusion in this. Okay, everybody, done. Now let's move back. So that's our posterior staphyloma seen in cases of myopia. What are the other signs, everybody? Vitreous hemorrhage and rhegmatogenous retinal detachment. This completes our list of important fundus signs in case of myopia, specifically seen in cases of high myopia, pathological or degenerative myopia. If you have been able to understand all these signs are occurring due to one cause, and that is increase in axial length. Three things are stretching, everybody. What are the things which are stretching? Retina, choroid and sclera. And because of the stretching, something is breaking, something is hemorrhaging. So blood vessels are hemorrhaging because they are getting stretched. So they are leading to Foster Fuchs spots. Blood vessels are hemorrhaging leading to vitreous hemorrhage. Sclera is stretching leading to posterior staphyloma. Choroid choroid is stretching leading to lacquer cracks. Retina and choroid are stretching leading to temporal myopic crescent. So everything is based on stretch, stretch and stretch. Am I clear to everybody? So that's all about the science of myopia and hypermetropia, everybody. I hope you have been able to understand these fundus signs mainly. Now, after we have been able to complete the science, let's move on to the treatment of myopia and hypermetropia. Number one, everybody, you are wearing the treatment. What do we commonly do? We wear spectacles for myopia. But which spectacles? Are we wearing spherical or cylindrical for myopia? I hope you understand, because myopia is a spherical refractory error, we are wearing spherical spectacles. Spherical spectacles, but which lens? Concave or convex? Myopia, concave or convex? Think about it. The image is from in front of the retina. We need to send it back. To send it back, we need to diverge. Which lenses are diverging lenses? Concave. And concave are powered minus. Minus because the power is more. So concave lenses or diverging lenses. So I hope you understand this. If I draw such an image, okay. In front of this, I have placed a concave lens. Concave lens, everybody, will first lead to slight divergence, and then the light rays will converge, so that ultimately the image gets formed on the retina. Okay, everybody? So this is a treatment for myopia in spectacles. Now, what will be the treatment of hypermetropia, everybody? Again, obviously, spectacles. Again, obviously, I hope spherical, because this is also a spherical refractory error. But instead of concave, it will become convex, because now the image was forming behind the retina, so I need to converge it more. Converging lenses, convex lenses or plus lenses. The power of the eye is less, so I need to increase the power, guys. Yes? I hope we are clear about this. No confusion about the spectacles at least. Now, secondly, what we can do is, obviously we can do surgeries for both myopia as well as hypermetropia. Even though I am listing some of the names of surgeries for hypermetropia here, let me be very clear when I say that actually clinically they are not done. We do not recommend surgeries for hypermetropia. Okay? What are the names of the surgeries, everybody? Number one, conductive keratoplasty. Secondly, thermal laser keratoplasty. And lastly, hyperopic LASIK. LASIK for hypermetropia. Okay, just listing the names, not going into the details at all, everybody. Okay, that's the surgeries for hypermetropia, the mainstay of the treatment being spectacles, as already explained to you. Now, surgeries for myopia, very commonly done. The surgery which was done in 70s, 80s, everybody, an old surgery is radial keratotomy. Radial keratotomy. The first thing that I want you to notice from this name is the fact that I have used the word kerato. Kerato means the surgery is being done on which part of the eye, everybody? The surgery for myopia is being done on cornea. Yes? What do we do in this surgery? If this is my cornea, everybody, peripheral partial thickness incisions were given like this. Okay? What did these incisions do, everybody? They healed. When they healed, there was a little bit of fibrosis. So the fibrosis pulled the periphery of the cornea. There will be contracture. They will pull. When they are pulling, what we are trying to do? We are trying to flatten the curvature of cornea. Why are we trying to flatten the curvature of the cornea? Because we know the power will be decreased if the curvature gets decreased. So in all the surgeries on myopia, we are trying to flatten the curvature of the cornea. Okay? In radial keratotomy, it was done because of peripheral cuts pulling on fibrosis, leading to central curvature getting flattened. Done? This is no more done, guys. What is done nowadays are laser surgeries. I know you are saying LASIK. But apart from LASIK, the surgery which is done is called as PRK, photo refractive keratectomy. Again, focus on the word kera. Again, the surgery is getting done on the cornea. Okay, everybody? Photo refractive keratectomy. This is useful from -2 diopter to -6 diopter. Obviously, apart from PRK, the name of the surgery is LASIK, which we usually hear if you have gone to an ophthalmologist for an opinion, they will say get LASIK done. Laser assisted in situ keratomylosis. Okay? Keratomylosis. That's the full form of LASIK. Please again focus on the word kerato. Okay? Now, in both the cases, the first thing that comes into my mind is laser. So, which laser is getting used? Which laser is getting used, everybody? So, the laser which gets used is excimer laser. Excimer laser. Excimer is the short form for excited dimer. If you remember a little bit of your chemistry, guys, one atom can be given energy and jump from a lower orbit to a higher orbit. Yes? So you are exciting the lower orbit molecule, jumping it into the higher molecule. Excited dimer made up of two molecules. Okay? So what we use is argon fluoride, ARF, with a wavelength of 193 nanometers. Okay, so excimer laser is the name of the laser. The compounds used are argon and fluoride, and the wavelength is 193 nanometers. Now the question comes into my mind, just like all the other lasers I have discussed, what is the mechanism? What am I doing? Am I burning the cornea? Photoablation. Am I coagulating the cornea? Photocoagulation. Or am I disrupting, breaking the cornea, creating a hole in the cornea? If you are smart, you know I am not creating a hole in the cornea, it will be perforation. The confusion can be between photoablation and photocoagulation. Please remember, we are trying to photoablate. When we burn the cornea, we make it thinner. When we make it thinner, we flatten the cornea. Okay? Okay? So if I ask you basic steps of LASIK surgery. So first of all, we use a microkeratome to create a nasally hinged epithelial flap. Then we ablate the corneal stroma. Roughly 1 diopter is equal to 10 micron ablation. Residual stromal thickness should be greater than equal to 250 microns. A little bit of technical knowledge here, everybody, but very easy to learn, very easy to remember. That's why I've just listed it for you. If you focus on this, everybody, this is round, this looks like cornea. Yes, I am saying I take a microkeratome. Microkeratome means what basically? A knife, everybody. So I'm taking a knife and I'm going under the epithelium. I don't want the laser to damage my epithelium. Yes, I don't want the laser to burn my epithelium. So I'm creating a flap. I have gone and I have created a nasally hinged flap. I hope you understand this, okay? So I have created an epithelial flap. Now I have opened that flap. Once I have opened that flap, what is visible to me here, everybody? This is the stroma now, okay? Now I fire the laser burns onto the stroma. I burn the stroma and then I close the epithelial flap back. This epithelial flap will heal and the LASIK surgery will be done. I have burned, I have flattened the cornea. You understand this, everybody? So the main thing is creation of the flap. And if you understand, a lot of complications are due to this flap, immediate post-operative complications. We have to ask the patient not to rub the eyes. If the patient rubs this eye, this hinge may get broken off and the epithelium and this whole flap may get lost. It cannot regenerate the whole flap. It will regenerate, but it will regenerate with opacity. So you will actually end up losing your vision. So that is probably the only precaution we ask the patient to take. Okay, everybody? It takes around 4, 5 days, 7 days for the flap to heal. Am I clear to everybody? Done. This is how we do laser surgery, that is LASIK. Now, there are certain contraindications to LASIK. Again, if you have ever gone to an ophthalmologist, the first thing the doctor will ask you is what is your age. If your age is less than 18 years, it is a contraindication. Secondly, they will ask you when did your spectacle number last change. If your spectacle power is not constant for past 1 year, then that is a contraindication. Because I don't know how much to burn your stroma because your power is changing. I may overburn, underburn. Yes. And thirdly, the doctor will measure your corneal thickness. If your corneal thickness is already less than 450 micron, then there are chances that when I burn your stroma, I am not able to maintain your residual thickness of 250 microns, and that is why it is contraindicated. I hope I am absolutely clear about this. Okay? LASIK can be done for -2 diopter to -13 diopter. So it has a larger range, everybody. -2 to -13 diopters. No confusion about this, everybody? We understand the laser surgery, how it is done, what is the laser and what are the contraindications. Now, continuing in the list of laser surgeries, number 1 PRK, number 2 LASIK, number 3. If I ask you what is the latest surgery, the newest laser-based surgery which has been developed for the treatment of myopia, does anyone of you know the name? Yes, very good. If somebody of you is saying smile, I am smiling, you should also be smiling. Also at some places known as relax. Both these are basically different names for the same surgery. Smile is being more commonly used. What is the full form of smile, everybody? Small incision lenticule extraction. SM, small incision lenticule extraction. Relax, refractive lenticule extraction. So if you basically see, there is lenticule extraction. Okay. Now, what do we do in this surgery? I'll just draw a diagrammatic representation for you. Let's say this is my cornea, everybody. Okay. We don't burn the part of the cornea. What we do is, through a laser, we create 2 cuts. Let's say I'm firing the laser. We create an inferior cut. Then I fire the laser again, we create a superior cut. Intrastromal 2 cuts are created. Then I will take a blade. I will join both these cuts. So what have I created? I have created a piece of stroma which I have cut in the center of the stroma. Then this piece of stroma, which is called the lenticule, is removed. You understand? So laser giving 1 cut, laser giving another cut, a lenticule, a button is created, and then this lenticule is removed. When this lenticule is removed, what have I done, everybody? I have decreased the thickness, and thus basically I have decreased the curvature. Yes or no? I have flattened the cornea. I hope you understand this. Yes? So I am doing the same thing, but the laser used in this case is ND glass. Yes. Am I clear? This is a precise laser. I can aim at a certain depth and I can create a cut. Okay, everybody? That is how this works. This is an entirely different surgery. This does away with the creation of the flap. So we say it is a flapless and bladeless surgery. because we don't need the microkeratome. So it is a bladeless and it is a flapless surgery. That is the main thing. Flapless. Please focus on this. Okay, everybody. The same laser which was used for the latest surgery in cataract, FLA, CS, femtosecond laser, ND glass, the same laser is being used in smile surgery also. I hope we understand this. I hope we understand the name for this. So these are our laser-based surgeries. Now, after the laser-based surgeries, everybody, what are the other surgeries you can do? So I'll just go back and so that you can see the numbering. The first surgery was radial keratotomy. The second surgery were laser surgeries. Then comes C, the third surgery. The third surgery, I am calling it Fucala's operation. Fucala's operation is extraction of clear lens and implantation of IOL. If you understand, basically I am doing a cataract surgery. I am removing the lens, I am implanting an IOL. But even without any opacity, I am removing the lens. Extraction of clear lens. Why am I doing this? If you try to understand it, let's say I have a 24-year-old male patient with a minus 17 diopter myopia. Yes, there are patients like this. Yes, there are. They exist. So either I give a minus 17 diopter spectacle, not possible. Can I do LASIK? No, LASIK is limited minus 2 to minus 13D. What do? I say, let's look at my lens. What is the power of my lens? 16 diopter to 19 diopter, plus 16 to plus 19. If I remove the lens, I am basically decreasing the power of the eye by around 16 to 19 diopter. Whatever residual power is there, I will implant an IOL for that, whether plus 1, plus 2, minus 1, minus 2. And this is called as Fucala's operation. So this is done in very high myopia. Similarly, if I say the next surgery, D, which is called as PRL, phakic refractive lenses. Phakic refractive lenses. Focus on the word phakic. I am not removing your lens, you remain phakic. So, we implant an IOL. Writing the name, guys. This IOL is known as ICL, implantable columnar lens, over the normal crystalline lens. Am I clear? So I am not removing your lens like in Fucala's, I am not removing it. I am just calculating your power and I am implanting that power of IOL over your normal crystalline lens. Phakic refractive lens. You remain phakic, but still I have implanted a refractive lens. And that lens is ICL, implantable columnar lens. Again, this also is done in high myopia. Let's say somebody comes with a minus 12, minus 11, minus 10, something like that, and there is a contraindication to LASIK, then we have to do a PRL. But these are only done in young age, everybody, because the patient has to live a long life. That is why we do it in a young age. Then, apart from the surgeries, everybody, our last possible treatment is contact lenses. I hope you understand it, contact lenses. Contact lenses are preferred in high myopia. If you are a minus 1 or a minus 2, then you are wearing it because you want to look good, because you don't want to wear a spectacle. But if you are a minus 8 or a minus 10, then we prescribe actually contact lenses over spectacles because of a lot of reasons, not going into the detail. Please remember, for high myopia, contact lenses are preferred over the spectacles. That finishes my treatment for myopia. I hope you have been able to understand the surgeries. Surgeries for myopia are done constantly, commonly. That is why questions will be asked from it. Hypermetropia, as I said, surgeries are not done, so very rare to get questions asked from it. That completes my topic of myopia as well as hypermetropia, everybody. I hope nobody has a confusion in this. Yes, so you remember myopia by the word more. Myopia, more, minus. Hypermetropia is the opposite. You just keep linking the same thing, that everything is getting lengthened, everything is getting more. Because the curvature is getting more, all the surgeries are decreasing the curvature. Because the axial length is getting more, all the fundus signs are getting seen. And you shall be able to remember both the refractory errors. Am I clear, everybody?